Hello. So we're going to go over the bile ducts, and we need to understand one important thing. That is that sonography is the modality of choice in the evaluation of bile ducts for suspected disease. And there are a number of key terms. There's acute pancreatitis, which is inflammation of the pancreas, secondary to the leakage of pancreatic enzymes from acinar cells into the parenchyma of the organ. There's the ampulla ovata, which is this is the merging point of the pancreatic duct and the common bile duct right before the sphincter of Oddi, and we refer to this as the hepatopancreatic ampulla. Ascariasis is an inflammation of the small intestine caused by Ascaris lumbricoides, a parasitic roundworm. Biliary atresia is a congenital disease described as narrowing or obliteration of a portion of the biliary tree. Biliary colic is pain secondary to the blockage of the biliary tree. Biliary stasis is a condition in which bile is stagnant and allowed to develop into sludge. Bilirubin is a yellowish pigment found in bile. It's produced by the breakdown of old red blood cells. Biliverdin, that is the green pigment found in bile, so both of them create that greenish-brown pigment of bile. Caroli disease is a congenital disorder characterized by a segmental dilatation of the intrahepatic ducts. The central dot sign is the presence of echogenic dots in the non-dependent part of the dilated duct. This represents small fibrovascular bundles seen with Caroli disease. Charcot triad, fever, right upper quadrant pain, and jaundice. That is the triad associated with cholangitis. Cholangiocarcinoma is a primary bile duct cancer. Cholangiography is a radiographic procedure in which contrast is injected into the bile ducts. Cholangitis, inflammation of the bile ducts. Chronic pancreatitis, recurring obstruction or recurring destruction of the pancreatic tissue, and this results in atrophy, fibrosis, scarring, and development of calcifications. The double duct sign is coexisting dilation of the common bile duct and pancreatic duct. Endoscopic retrograde cholangiopancreatography is an endoscopic procedure that utilizes fluoroscopy to evaluate the biliary tree. Hepatopancreatic ampulla is at the level of the biliary tree where the common bile duct and the main pancreatic duct meet, and it may also be referred to as the ampulla ovata. The hepatopancreatic sphincter is a muscle that controls the emptying of bile and pancreatic juices into the duodenum. It may be referred to as the sphincter of Oddi. Inflammatory bowel disease. This is chronic inflammation of all or parts of the bowel. Klatskin tumor is a malignant biliary tumor located at the junction of the right and left hepatic ducts. Murizi syndrome is a condition when the patient presents with jaundice, pain and fever secondary to a lodged stone in the cystic duct. Parallel tube sign is an enlargement of the common duct to the size of the adjacent portal vein within the portal hepatis. Pneumobilia, air within the biliary tree. Puritas, severe itchiness of the skin, the shotgun sign. This is enlargement of the common bile duct to the size of the adjacent portal vein within the porta hepatis, referred to as the parallel tube sign. Not to be differentiated from the parallel tube sign. And the sphincter of Oddi is a muscle that controls the emptying of bile and pancreatic juices into the duodenum. Ulcerative colitis is an inflammatory bowel disease that leads to the development of ulcers within the bowel. So, gallbladder anatomy. So, there's normal anatomy of the biliary tree, the gallbladder, and adjacent vasculature. Bile is a vital digestive fluid, and it is produced by the liver. It is important to note that cholesterol is a major component of bile, although this may include other key elements that aid in digestion, such as bilirubin, the yellow pigment, and biliverdin, the green pigment, as well as bile acids. The function of the biliary tree is to provide a conduit. Biliary tree provides a conduit for bile to drain from the liver into the duodenum. So bile first accumulates in the small intrahepatic biliary radicles, and these are located throughout the liver. These are ducts. They're quite small and they're scattered throughout the liver parenchyma, and they form part of the portal triad. Each portal triad contains a small branch of the hepatic artery, the portal vein, and the intrahepatic ducts. And the intrahepatic ducts, also known as biliary radicles. From these small biliary radicles, bile flows into either the right or left hepatic duct. The right and left hepatic ducts eventually unite to form the common hepatic duct. Bile then travels only a short distance to the gallbladder, where it is concentrated and stored. So bile is produced in the liver, and it then travels through the right and left hepatic ducts, and then it eventually is stored in the gallbladder. Now the gallbladder is attached to the biliary tree by the cystic duct, and the point of attachment marks the proximal margin, the common bile duct. Okay. The cystic duct contains structures quite small. We call them the spiral valves of Haysetter, and these are small projections of tissue that prevent the cystic duct from distending or collapsing. When stimulated by cystokinin, which is produced by the duodenum, the gallbladder contracts and empties bile into the biliary tree at the level of the proximal common bile duct. Bile travels from the common bile duct towards the duodenum, and as it travels, it eventually meets the main pancreatic duct at the ampulla of Vater, or the hepatopancreatic ampulla, where pancreatic juices are mixed with bile. And at the sphincter of Bile, also referred to as the hepatopancreatic sphincter, bile and pancreatic juices flow into the duodenum. This fluid is mixed with chyme in the duodenum. Chyme comes from the stomach, and it aids in digestion. So in summary, bile flows from the liver. It is generated in the liver. It flows through biliary radicles, and the biliary radicles are parts of the portal triad, referred to as intrahepatic ducts, and they eventually drain into the right and left hepatic duct. The right and left hepatic duct then eventually unify to form the common hepatic duct, and then the cystic duct joins the common hepatic duct to make the common bile duct. From the common hepatic duct, bile enters the gallbladder where it is stored, and through the action of cholecystokinin released by pancreas, the gallbladder contracts and bile flows, and eventually it meets the pancreatic juices released in the pancreas, and through the sphincter of Bile, bile enters the duodenum. So how do we scan for bile ducts? So it's quite important to make sure your patient is fasted for 8 hours. And then you have milk or for at least 4 hours before the sonogram. And we can differentiate the common bile duct from the common hepatic duct once it's recognized posterior to the head of the pancreas or inferior to the gallbladder neck. And delineation may be difficult. So in general, we're looking for a common bile duct diameter that is less than 6 millimeters. If it is greater than that, we consider this abnormal, and we should ascertain the cause of this. So if in the case of biliary tree disease, we look at laboratory results, alanine aminotransferase, alkaline phosphatase, serum bilirubin, and gamma glutamate transferase, as well as the bilirubin is often elevated in the presence of biliary obstruction or disease. You can also look for pancreatic laboratory results such as amylase and lipase, and these can aid in identifying biliary abnormalities. Intrahepatic ducts are considered dilated if they exceed 2 millimeters in diameter. And whenever we're placing calipers to measure the duct, we should measure them from inner wall to inner wall. Now remember, the Shotgun sign or the parallel tube sign describes the enlargement of the common duct to the size of the adjacent portal vein within the portohepatic. Also, coexisting dilation of the common bile duct and pancreatic duct has been referred to as a double duct sign. When these findings are present, we often employ Doppler to delineate vasculature from bile duct. So you can see here a longitudinal image of the common bile duct. And I'll just zoom in. So the common bile duct, the hepatic artery, and the portal vein, that's the inferior vena cava. And there's the bile duct. And here is a Doppler of the common bile duct, the intrahepatic duct that has been dilated. So, the certain pathologies. So first and foremost, biliary obstruction and jaundice. The origin of bile is within the liver, and we consider this the proximal portion of the biliary tree. Conversely, the common bile duct segment closest to the pancreatic head is considered the most distal segment of the biliary tree. So often, as a rule, biliary dilatation will occur proximal to the level of obstruction. The most common level for an obstruction to occur is a distal common bile duct, and in most instances, the extrahepatic ducts will dilate first. Therefore, with obstruction of the distal common bile duct, there will be eventual dilatation of the common bile duct, the gallbladder, and the common hepatic duct. The most common causes are polydolithiasis, chronic bronchitis, acute pancreatitis, and pancreatic carcinoma. As a result of this obstruction, patients will eventually suffer from jaundice. And jaundice occurs as a consequence of bilirubin accumulation within the tissues of the body. And we can find bilirubin turning the skin and the sclera yellow if it is allowed to accumulate. There's another pathology of the bile ducts that we've seen when you're looking at the pathology of the gallbladder, and that's polydolithiasis. Whenever we have bile stasis occurring, gallstone inflammation is probable. Choledolithiasis describes the presence of gallstones in the bile duct. These stones typically form in the gallbladder and pass into the biliary tree. Rarely they can form the ducts themselves. The gallstones located within the common bile duct are considered the most common cause of obstructive jaundice. Most stones will be located near the armpit or vata, and this can be difficult to image secondary to neighboring bile gas shadows from the stomach. But we can observe for elevated laboratory values of ALP, ALT, and the bilirubin. One of the uncommon manifestations of choledolithiasis is Mersey syndrome, and this is a clinical condition in which patients present with jaundice, pain, and fever secondary to a large stone in the cystic duct, together with subsequent compression of the common duct. The sonographic findings and symptoms may appear much like those found with cholecystitis, and Mersey syndrome may be suspected, but it is typically diagnosed by cholangiography. Clinical findings of choledolithiasis include jaundice, elevated functional tests, right upper quadrant pain. Sonographic findings include echogenic foci within the bile duct, which may or may not shadow, and these have a very distinct shadow, and there may be some biliary dilatation. So within this image, a gallstone is noted within the distal common bile duct, and the portal vein is also seen, and this is the common bile duct. Cholangitis is inflammation of the biliary duct, and this occurs when the duct thickens and thickens greater than 5 millimeters. The most common cause can be a case of choledolithiasis, and there are several types of cholangitis. It can be bacterial, oriental, or sclerosing. Acute bacterial cholangitis is typically preceded by a biliary obstruction, and patients often present with fever, right upper quadrant pain, and jaundice, and we refer to this as the charcoal triad. That is fever, jaundice, and right upper quadrant pain. Patients with bacterial cholangitis may also suffer from leukocytosis and elevated laboratory values. So we can have acute bacterial cholangitis, which is caused by bacterial accumulation secondary to obstruction, and the bacteria can be introduced through any kind of procedures that are required to image the gallbladder, certain fluoroscopy procedures such as cholangiography. Pus may be noted within the bile duct at low-level levels. You can have AIDS-associated cholangitis, which is associated with HIV, and most often results from an infection with Cryptosporidium or cytomegalovirus. Oriental cholangitis is oriental in origin, meaning it is endemic to Asia, and due to immigration it can be seen in America. Sclerosing cholangitis is characterized by fibrotic thickening of the bile ducts. It most often affects young men and associated with inflammatory bowel disease or ulcerative colitis, with an increased risk for cholangiocarcinoma. So sonographic findings of cholangitis include biliary dilatation, biliary sludge or pus, choledolithiasis or bile duct thickening. Here we have an example of Mersey syndrome, and a stone noted lodged in the cystic duct, and this compresses the common bile duct, leading to obstruction and dilation of the extrahepatic biliary tree. Next to that we have cholangitis, where the internal walls of the duct can be noted, indicating there is inflammation. might also be as a result of prolonged acute cholecystitis. Hemophilia is diagnosed sonographically when we observe an echogenic linear structure seen within the ducts, and it may be difficult to differentiate hemophilia from intrahepatic stones. However, hair in the bile ducts may be linear in appearance and will most often produce a ring-down artifact and some dirty shadowing. Clinical findings include symptoms of acute cholecystitis, upper quadrant pain, and Murphy sign that is positive. Sonographically, echogenic linear structures within the ducts will produce ring-down artifacts and dirty shadowing. Ascariasis is an infection of the small intestine by Ascarias longicoides, and that is a parasitic roundworm. And this roundworm is transmitted by the fecal oral route developed in the small intestine, and it makes its way to the biliary tree via the anterior aorta. Some patients may be asymptomatic, or they may have symptoms of inflammation in the biliary tree, or maybe the pancreas or the gallbladder. Sonographically, the worm will be noted within the biliary tract as an echogenic linear structure in the sagittal plane, and movement of the worm within the duct would confirm this diagnosis. And so you'll see the worm moving in the echogenic linear fashion. Cholangiocarcinoma and Katzkin tumors. These are primary biliary tree cancers. And primary sclerosing cholangitis is the most common risk for cholangiocarcinoma. Although recurrent biliary infections and stone diseases also increase this risk, it can be either intrahepatic or extrahepatic in location, and both are common manifestations of cholangiocarcinoma. These tumors are located at the junction of the right and left hepatic ducts, and they cause dilatation of the intrahepatic ducts. And patients will present with jaundice, pruritus, unexplained weight loss, and abdominal pain. And occasionally, a solid mass may be noted within the liver or other ducts in the biliary tree. Sonographic findings include dilated intrahepatic ducts that abruptly terminate at the level of the tumor, and a solid mass may be noted within the liver or within the ducts. Next, we move on to pediatric pathology. That is biliary atresia, and it's a congenital disease that might be caused by the virus, and it's described as narrowing or obliteration of all or a portion of the biliary tree. Eventually, infants will suffer from cirrhosis and portal hypertension. Sonographically, biliary atresia will appear as absent ducts. The gallbladder may be absent or small, and there may be evidence of a triangular cord sign. And the triangular cord sign depicts something that is vascular, echogenic, and tubular. And this will be seen anterior to the portal vein, and it would represent the replacement of the extrahepatic duct with a fibrous tissue in the porta hepatis. Sonographically, you will not see the biliary ducts. You will see signs of cirrhosis and portal hypertension. So here you can see a vascular fibrous cord anterior to the main portal vein. Pediatric pathology, polyductal cysts. There are 4 different kinds. The most common being described as a cystic dilatation of the common bile duct, and these are usually discovered in infancy or in the first decade of life. Patients with these kinds of cysts present with an abdominal mass, jaundice with jaundice, pain, and fever. As we can see here, there is a common bile duct, and this is quite evident. We have the hepatic artery shown, and we have the gallbladder itself, and there's a portal vein, and there's marked focal dilatation of the common bile duct. We can also have Caroli's disease. This is a congenital disorder characterized by segmental dilatation of the intrahepatic ducts. It is often associated with cystic renal diseases and may precede the development of cholangiocarcinoma. Patients will present with pain, fever, jaundice, and signs of portal hypertension. Sonographically, we will see segmental dilatation of the intrahepatic ducts. The patient may also have cystic renal disease, and there will be a central dot sign. Central dot sign appears as epigenic ducts in the non-dependent portion of the dilated duct. So here we can see dilated ducts, and they demonstrate the central dot sign, often associated with Caroli disease, representing small,